I'll open it up for questions. I want to actually just begin by asking you both. You're in very different pieces of the clinical spectrum in how we work, settings which we work. I guess I'd ask you, Dr. Morse, as somebody who's finishing their training, we often are criticized as academic centers for saying, well, go do this out solely in an outpatient setting, out in the community. And I'd ask you, was there a benefit for you? You just said you came off of the ICU. Is that clinically relevant for you to be going and working in primary care to have to do those kind of training experiences? And Dr. Baker, I think, would we want to have all of your neurosurgery trainees off working in focused factories, or do we get some benefit from having all these different health professionals and specialties training together?
So it's absolutely relevant. Part of the reason why I chose to come to a large New York City public hospital is I knew I wanted a spectrum of experience. I knew ultimately that I would probably be working in the outpatient setting primarily, but it's so important to see that spectrum of disease, to see what a critically ill patient looks like, and to learn how to manage that. The medicine is the same. I may not see those ventilated patients in the outpatient setting, but it's absolutely pertinent to have that training to feel comfortable taking care of your patients.
It's a great question. I trained at Parkland Hospital in Dallas, which is another Bellevue-like institution. And the one thing that I would say to Dr. Grover's question is that neurosurgery is the management of some very sick and very complicated patients. Some of those patients need an operation. Okay, that's something that we do. Those patients will not successfully get to the elevator on the way out if we don't have great infrastructure. That's great anesthesia, cardiology, critical care, radiology. It simply cannot be done safely. And you hear the word team science. That's such a critical element of what we're trying to do to advance the field. Team medicine is exactly the same thing. It is deploying colleagues from a variety of disciplines that reinforce each other, that help get Mr. Jones to the parking garage.
Questions or comments from folks? Yes, sir.
I didn't know they had a school there. That's great.
Yeah, it's a real problem. The average graduating debt now among our USMD graduates is about $175,000. And Matt, raise your hand. He's my student loan and indebtedness guru, so we can certainly follow up with him if you have questions. We have been hopeful at some of the changes made to student loan policies in the last couple of years. I think Pay As You Earn has something that is going to be effective, particularly the public service loan forgiveness program. It was disheartening then to see that the president in his budget wanted to cap that loan forgiveness at $57,000. Not going to help our graduate and professional students in medicine or in science. And similarly, there's been proposals in Congress to tax their student loan benefits. So I think we have a lot of work to do. There's a broader issue here of how do we stop that high escalation of medical education. I think one of the things that we're learning now is that adults learn in a very different way than even a couple of years ago when I or others completed medical school. So can we actually leverage technology to reduce some of those costs? And I agree that it's not just debt driving student decisions, but again, if you want to really incentivize people to go into particular fields that are neglected, you've got to figure out how to reward them. And it's not just the debt, but if you can see that you're making $400,000 a year working 4 days a week, and you're going to be making $200,000 a year, which is a great salary, but it's that discrepancy. It's then saying, you know, and I got to run around, you know, 5 days, 10-hour days, and then finish my charts on the weekend. That itself is discouraging. I don't know how that's factored into your decision making.
No, your question is valid. I actually entered the whole medical process very aware of the debt that I would incur. I was 28 when I started medical school, which is around the time my colleagues in finance had already purchased their own house, so I was far behind. At that time, I did a lot of research, and I decided that the public service loan forgiveness program was ideal for me. I also looked into the National Health Service Corps, but for various reasons, I thought public service loan forgiveness was better. As Dr. Grover said, the salary that I will make is a salary that's better than 90% or so, I'm just throwing out a number, of most people in this country. And what is important to me is that I'll be doing a job that I love. But I do feel that it's important to address, and hopefully we can come to some solutions in the next few years.
Yes. So there are about 10,000 positions out of the 120,000. Remember, this is all years of training, not just that first year. About 10,000 that are being completely self-funded without Medicare support for those positions. Now, the VA is a terrific partner in GME. They support almost 10% now, 10% of our positions. Some support from Medicaid and public health service programs, Title VII, which are all critically important, but there's a lot that have not been supported. The challenge there is we've been able to grow those in response to clinical need and community needs, but they have been financed through clinical revenue of our faculty and our hospitals and health systems. The challenge we face now is that with a number of factors, but reduced clinical revenue that we're all seeing across the country, and it will probably get even tighter, is we're not sure we can even continue to support those existing positions over the cap. I mean, I think Dr. Baker showed you some of the numbers there. It's a significant investment. Now, we're not going to stop people's programs in the middle, but again, you're planning for 10 years out, and so people are making decisions now based upon the policy you decide to. Yeah, and that was the Medicare Payment Advisory Commission. MedPAC, very smart, great staff, but they're relying on a regression analysis, and I'm happy to walk through the statistical models with people. I used to be a health economist after this, but I won't torture most of you. And they do a simple plug-in of, well, what are the Medicare costs and what do we think are attributable to that research and standby capacity and other things associated with having a teaching hospital? What do those costs add up to? And they come up with a number. That number is not reflective of a lot of the inherent costs that we have that aren't on the Medicare cost report. So, and I would also argue that these things are sort of very difficult to pull out one by one. If we had a perfect system and we built it from the ground up today, a health system and an education and training system to go along with it, I think we would be much more explicit about, well, let's pay for care to the underserved. Let's pay for care in specialties that are cognitive over losing money. Let's pay for the full cost of a trauma center, a level 1 trauma center, which, oh, by the way, requires that you have a training program and that you do trauma-related research. Let's pay the full cost for research and not depend upon institutions to invest 30% of the cost of that research for every grant they get. But we don't have that. We have an incredible cross-subsidization, and so the challenge is you take resources out. Leaders have to make decisions. Do I train fewer people? Do I shut down my level 1 and take it to a level 2? Do I close the geriatrics clinic? Do I close the sickle cell clinic? And that's the real challenge here. We're not measuring all of those associated infrastructure costs. Other questions or comments? So after the SOAP match, we had roughly 475 USMDs, 425. 412, okay. SNAS is the other expert. That went unmatched. So again, I think we did a little better this year for a variety of reasons, and we're hoping that those people don't just get stuck in that pipeline. That was USMD graduates only. Final.
What about what is AAMC and our AAMC and doing from in terms of selecting the right people together? I mean, AAMC must have a sense that the prototype applicant that will serve the longest career with the most hours over the field of what are they doing?
Yeah, you know, shockingly, we don't have fantastic data there. We do know that we have a couple of problems in terms of medical education and that beginning of the pipeline. One is we predominantly take students from the highest family income earners in the country. 80% of our students come from the top 20 percentile of family income earners. You're never going to get the kind of diversity and breadth of view that you need if you stick with that. So part of that is building up the K through 12 pipeline. If I've got in some cities, half of African-American students that are male that aren't finishing high school, I can't get to them in college or in a post-bac program, so those things have to be addressed. We also have started something called holistic review in a couple of dozen of our medical schools, where really it's a lot easier to just look at your MCAT scores in a GPA from college and say, well, I'm only going to take people that are above this line. And what we've really tried to do is have discussions with our institutions and their admissions committees to say, let's think about first as a cutoff, who's going to make a good doctor? And then make sure they have the academic pretensions to ensure their success. So that's much more labor intensive. We've only got it going at a couple dozen schools right now, but it's something that we're hoping to expand, and also working with other health professions, education groups in nursing and dentistry to help them with that as well. So I think we're out of time. I think our panelists will be around for a little bit if you have follow-up questions. Thank you all for coming, and thanks to the panelists for being here.